Good morning, everyone. My name is Maya Luria with TMC for Seniors, and I am thrilled to be back. I know we had a week off last week where we were not online. So today we're going to be talking about the power of prevention, vaccines for older adults. I have Natalie Norem here with me. Natalie is a family nurse practitioner. She's board certified with TMCOne. How are you today, Natalie?
I'm great. I'm happy to be here.
Good. So I am looking forward to hearing all about what vaccines we should really be looking at. I know this has been a hot topic for everybody. So we're going to go ahead and I'm going to put your slides up. You do have some folks that are watching in from who are tuning in online. So if you are watching from home and you have a question, please go ahead and put those into the chat and we'll address those afterwards. I'll turn it over to you, Natalie.
Thank you, Maya. Again, I'm Natalie Norem, nurse practitioner. I actually think that I see some familiar faces that were at my wound care talk. So thank you for coming back today. I'm really excited to be here. I'm very passionate about preventative care. I have a primary care background for 17 years, and vaccines are a huge component of preventative care. So let's dig in. Just a little bit about me. I've been a nurse now for 23 years, nurse practitioner for 17. I have 2 biological kids and 2 step kids. There they all are. And they're all fully vaccinated, by the way. And I just want to reiterate that we're going to give you some evidence-based information because there is a lot of non-evidence-based information out there about vaccines. So I'm going to take you all back to high school biology class. And we're going to talk a little bit about the history of vaccines because I think that's important to how we got where we are today. And I'm a science nerd, so I find it interesting. Something called variolation was practiced early on in 10th to 11th century China. And what they would do is take smallpox. And if you're not familiar with smallpox, it was a sort of related to chickenpox virus that would cause these horrible sores head to toe. And it was very contagious and it could be deadly back then because, of course, they didn't have the medical support we have. So no worries. They found out if they could take a little bit of a smallpox viral lesion and put it onto a person, then they would build up an immunity and maybe get mildly sick, but not get the overwhelming disease. So that was our first known practice of something similar to vaccinations. This method was used again in England in 1796, and Edward Jenner is our famous scientist who developed the first true vaccine. He noticed that the milkmaids that would milk the cows who had cowpox didn't get smallpox. So he noticed there was some kind of bridge between the two. And so he started, I don't know if you remember the story, but there was an 8-year-old boy. I don't know how he talked the mom into consenting to this, but that he scratched with some of that cowpox antigen and then exposed the 8-year-old to smallpox, and he didn't get the smallpox. So that was the first vaccination that we know of. So next we have Louis Pasteur in France, who did a lot with microbes, but he started developing vaccines for things like rabies and then applying scientific principles to vaccines. Then we come up more to our modern vaccines. In 1921 to 1937, we started having widely available tuberculosis, diphtheria, tetanus, pertussis, yellow fever, typhus, and influenza. So probably some of the vaccines you all got when you were children. And then in the 1952 to 1970s, when we really got into our sort of childhood vaccine schedule, we developed measles, mumps, rubella, meningitis, normalizing that children now get on that schedule. And then we progressed with our vaccine techniques. In 1981, we had our first recombinant vaccine, which was a hepatitis B vaccine. And then up to today in the 2000s and with the COVID pandemic, we had the groundbreaking mRNA vaccines, which are really effective, more like 90th percentile versus our old methods, which are more in the 50th to 60th percentile. So let's talk about how vaccines affect those in your age group and 65 and older and why this is so important. So as we age, our immune systems go down, which is a bummer, right? But why does that happen? So let's kind of dig into that and talk about why it happens. There's a couple different things. There is a gland that's right in the middle of your chest here called your thymus, and it's really important to producing T cells, which are a key important part of our immune system. That thymus gland starts to not produce those T cells as readily available and as robust as it was when you were a younger person. So that's one reason. The bone marrow is another part of our body that's really important for producing antibodies to different viral and bacterial infections. And our bone marrow just kind of wanes down as we get older. It's not as robust. It's not producing those healthy antibodies like we used to. As you age, you have more what we call oxidative stress. So that's just living on the earth, all of the environmental stressors that kind of break down our cells. And that leads to our immune system not being as active. And then, of course, older people tend to have more chronic disease. I'm talking about things like heart disease and diabetes and COPD. Those are also interfering with your immune system. So you can imagine if you have COPD and you're chronically coughing and wheezing, if you get a viral infection in those lungs, you're not going to be able to, as readily available, clear it out. You're probably going to get sicker and it's going to last longer. So a plug for going to your primary care and making sure your chronic disease is controlled. We know that if you keep your diabetes under control and your other risk factors, your immune system's going to function better. And then nutrition. Nutrition can be difficult as we age. Our mouths get more dry in some instances. Our taste buds and our smell aren't as acute. So we don't enjoy some of the nutritious foods we used to. Our GI system can slow down. So our appetite isn't as big, or we get more constipation. So those things can affect your nutritional status, and nutritional status is very, very important to your overall immune system if you're not getting enough of those vitamins and micronutrients and protein every day. And then all of this leads to that increased risk for being hospitalized from different infections, and even increased risk for death. So we kind of talked about protection and why vaccines are important, because they can stave off that infection before it becomes a problem. And we're going to get more into that. But I wanted to focus on herd immunity, because I think when we hear about vaccines in the media and social media, which has been terrible for vaccination, I think this topic gets kind of lost. Herd immunity is when you have a certain percentile of the population that's been vaccinated and had a response to that vaccine where it was effective. So it depends on the disease, and I would have to defer to an epidemiologist on the exact numbers, but somewhere between 80 percentile in certain diseases, 85th, 90th percentile for others. If we can get that percentage of the population vaccinated and antibodies build up, that really decreases the disease, whatever that might be going around. So you may all be aware of, when you were younger, you may know people that had polio, or you had a polio vaccine, or maybe your mom kept you in that summer and didn't want you around kids who had polio. I know I have some patients who have post-polio syndrome. So that we eradicated, which is in the United States. It's still out in the other parts of the world, which is pretty amazing, because we got our herd immunity up so high that the vaccine or the virus couldn't go around to another host and reproduce. So that's a very, very successful story, our polio vaccination in this country. And this is why schools have vaccine requirements, and hospitals, really want patients to come in during flu season that are only vaccinated, and why me as an employee has to get a flu vaccine, all of those reasons for herd immunity. Unfortunately, you may or may not be aware, we've had this historical decrease and decline in vaccinations, and we're going to talk about a couple things going on right now, like the measles outbreaks and pertussis outbreaks. And importantly, doing preventative health, especially with vaccines and your other chronic disease, that really helps you have a good quality of life. It helps keep you out of the hospital, keeps you healthy, you can socialize and do all your activities that you want, and that's what we want for you. So just a quick snippet on how vaccines are made, because I get questions about this from patients. There's, depending on the specific vaccine and who the manufacturer is, they use these cell culture systems. They may use human or animal cells in the labs to grow the virus, and then they synthesize genetic instructions out of that and get what we call an antigen. And then they put that in with a filler or a stabilizer, and then your vaccine's made. I'm totally oversimplifying it. It's a lot more complicated than that. But just so you're aware, that's kind of how they're made. So when I use the word antigen, that is anything that triggers our immune system to build up a immune response or an antibody. So an antibody is our defense system. They're the little molecules that go around in our bloodstream and eat, that cold virus that comes in. The antigen is the trigger. So that could be an infection itself. It could be a bacteria. It could be a virus. It could be a fungus. But with vaccines, we've sort of hijacked that great response that our immune system has. And we introduce the antigen through the vaccine and tell our body, make antibodies, but we're not going to get you sick with the disease. So that's the whole basis of how vaccines work. So let's dive into what is really recommended in the 65 and older age group. We're going to focus first on the respiratory diseases, because that's kind of the biggest risk factor when you get older, is getting pneumonia. Pneumonia is one of the biggest reasons for patients over 65 to end up in the hospital. And it's one of the biggest reasons patients over 65 pass away worldwide, not just in the United States. And pneumonia, if you're not aware, is a lung infection, a deep lung infection. I'm going to go ahead to this chest x-ray and come back. That red circle there shows there's what we call an opacity on the chest x-ray, where we can see a cloudiness, and that's where the infection's accumulating. It gets down into your alveolar, the virus or the bacteria or the fungus. Heard of valley fever that we have here in Tucson? That's a fungal pneumonia. It goes down there and your body responds to the illness by making mucus, and then you start coughing. It causes a whole inflammatory cascade to try to get all of that stuff out and get your immune cells in there, your antibodies in there, so it can make you have wheezing and swelling in there. In severe cases, it can leak into, the infection can get into your bloodstream and cause sepsis, and that's how people die from pneumonia. There's a variety of reasons. We were kind of talking about COPD and your immune system going down, why elderly patients are more at increased risk for pneumonia. And there are a variety of bacterial, viral, fungal infections that cause pneumonia, because I think sometimes patients just think pneumonia is one thing, but actually it's a lot of things. So we're going to go over those as it relates to vaccine. Oops, where did my slide go? There we go. So COVID, influenza, RSV, pneumococcal, those are all vaccines we have to prevent respiratory infection. And the reason we do that is because we don't want you to get pneumonia from any of them, and we don't want you to end up in the hospital, and we don't want you to die. Of course, we don't want you to get sick. Nobody likes to be at home with the fever and body aches for 4 days. It's miserable. But the main reason is these very severe complications. So COVID-19 came on the scene in 2020, and it was really bad for elderly patients. And you can see here that still to this day, 67.5% of all COVID-related hospital stays are in that group of 65 and older. So there's an unfair, what we call disease burden, or there's so much disease in that age group. And that's why we really talk about COVID-19 precautions and vaccination. Influenza, have you guys heard about our horrible flu season we're having this year? I actually just was listening to the news on the way over here, and they were saying that the CDC said there's 18 million flu infections going on right now, which is probably underreported. They don't get every single one for people who don't seek medical care. And there's hundreds of thousands of hospital visits already for influenza this year. So this also tends to affect the 65 plus crowd more. 50 to 70% of flu-related hospitalizations are in that age group. RSV, is everybody aware of this? Because we came on the scene with the vaccine a few years ago, so people are more aware of it, which is good. We used to talk a lot about RSV in preemies and neonates and babies because it makes them have a terrible nasal congestion, cough, and they end up in the hospital needing oxygen. But we also know that it affects older people too. So we talk about vulnerable patients, the young part of the age spectrum and the older part of the age spectrum. And so hospitalization rates for RSV are 300 per 100,000 in this high-risk group. So that's why we now have a vaccine available. Pneumococcal is kind of the classic pneumonia infection that people think of. And that's in that pneumococcal vaccine that we're going to talk about. And you can see here hospitalized pneumonia incidence in 65 plus is 847 to 3,365 compared to the 64 and younger, it's only 250 to 300. So, I mean, that's more than double. Going on to talk about more complications from these respiratory illnesses, COVID-19 accounts for 80% of related deaths in the 65 and plus. So that's it's big. So only 20% of COVID deaths are younger than 65. Influenza, again, 70 to 85% of seasonal flu deaths occur in 65. So think about that. Under 65, we're only talking about even 15 to 30% of those deaths. RSV, 6,000 to 10,000 deaths annually in the 65 plus. And then if you were to get pneumococcal disease and you're 65 and older, you have a 14% chance of passing away from it. That's how serious it is. So let's talk about the pneumonia vaccines. There's a lot of options now. There used to just be one or two, and every year or so I have a new vaccine rep in my office and I'm like, okay, wait, stop. How does this fit in to the schedule we already have? So I kind of wanted to go over all of them because it can be a little confusing. Our sort of old and first vaccine is that PCV 15. Many of you may have gotten that. That's been around for years, like since the early 2010s, which is fine. It works well, but they came out with some different products now. We have the Prevnar 20. We've got this Capvaxi, which just came out in the last couple of years. You may have seen commercials for that one. And then we've got the Prevnar 23. Those vaccines, the subsequent ones that are a little bit newer, tend to make your antibody response better. So they're just more effective. So you want to talk to your primary care and say, hey, I got this one this year. Do I need to get an updated one? And they can kind of go through the guidelines and the evidence for you. If anybody in my practice has gotten that older PCV 15, I've been giving the Prevnar 23. This Capvaxi is even supposed to have a more effectiveness than these older ones that just came out in the last couple of years. So some of my patients who are really high risk for pneumonia, say COPD patient, renal disease, really frail, somebody on oxygen, I have then added that in too, because just for that extra added benefit. I get the question though, is that going to hurt me if I get another pneumonia vaccine and I've already had one? Because technically you only need one when you're over 65. It's supposed to kind of follow you through the rest of your life. Doesn't hurt you. It's just going to make more antibodies. Our systems and bodies get hundreds of thousands, even millions, they think, of antigens that enter us every day from the germs and the microbes in our environment. So adding in a vaccine is just another thing for our immune system to do that our immune system's already doing every day. So I think that's important to remember when we talk about vaccines and how they work. And if you could take one thing home from my talk today, if you're older than 65, please get your pneumonia vaccine. It's probably the most important one out of all the vaccines in this age group. RSV vaccine came out, gosh, time goes so fast, doesn't it? I'm trying to remember. 2022, I think. And so all of us family practice and adult practice people were like, this is weird. This is a pediatric vaccine. Why are you talking about this? But then we started paying attention to the data, and we just had it before because we didn't have a way to prevent it that we do now. It is indicated at 60 if you're high risk for infection in a hospital stay. So that can be things like lung and heart disease, if you're in a nursing home, that kind of thing. But then when we get over, 60 to 74, when we get over 75, you're just already in that high risk group. So we're recommending it. So it is, of course, all these vaccines are shared decision-making with your provider, but I think now that it's been out a few more years, we're really comfortable with it. It's got a good track record, and we are really recommending it. Flu. So let's talk about the flu. Influenza is one of those nasty viruses that is just part of our environment, and it's all over the world. And how we make the flu vaccine is in the winter and the spring, our scientists start looking at the flu activity in Australia and Asia, because we usually get those strains over to us in our winter. And so they use their best educated guess to figure out which strains are going to be active this winter, and they make a vaccine. The most common vaccine we have now that we give to most patients is the quadrivalent. So that means it has 4 strains of the flu. The common strains are influenza A and influenza B, and that vaccine does cover all of those. Unfortunately, this year, the flu virus got very smart and tricky, and it got this, it was influenza A that's really common right now. It got a very sort of aggressive, what they call subclade K version, and it's not in our vaccine this year. But we do know that if you did get your flu vaccine, or you haven't, you still have time, please do it. If you have antibodies to another strain of influenza and you get exposed to this one that's not exactly matched in the vaccine, you usually do better. You get less sick, you have less hospital stay, because your immune system's like, oh, I kind of know what this is, I'm ready to fight it off. I don't have the exact antibody, but I can take care of this. Versus you don't have anything on board for your flu vaccine this year, you have a higher risk of ending up with pneumonia and in the hospital. The other portion to that is in the spring, typically flu season goes through February, and then in the spring we'll start to see influenza B strains that come out, and so you would still be, protected against that other strain that hasn't even arrived yet. In the 65 and plus age group, again, increases your risk for hospital stay and pneumonia, so it's really, really important. And for some reason, I mean, there are a lot of reasons. The last couple of years, I've had some resistance from patients where they used to not be resistant. So I just want to encourage everyone to make sure that they're listening to the correct resources, things that are science and evidence-based. Sometimes your family doesn't have that correct information, so maybe not listening to your family. And in all cases, not saying that they're wrong about everything, and talking to your primary care, because I just hate to see my patients end up in the hospital with the flu bug when I could have prevented it. That really makes me irritated. Okay, COVID-19. I know you're all aware of COVID-19. We have so many different versions of, one more thing about flu. The vaccine for 65 and plus is called a high dose flu. And so sometimes that can kind of be confusing and even scare patients. So I want to dive into that a little bit more. High dose flu vaccine just means you get a higher dose of that antigen, because your immune system when you get older just doesn't mount the kind of antibody response you did when you were younger. So if we can give you a little more antigen, it tends to stimulate your body a little bit better, and then you get a better response. It doesn't mean you're going to have more side effects. It doesn't mean you're going to have any more problems or reactions. It's just how your immune system works at that age. Okay, so COVID-19, most of my patients have had 1 or 2 vaccines at this point. It's not something that we're recommending for everybody anymore, because it's just not as strong as it used to be. Thank goodness for that. We're not seeing the hospital stays and the death rates and all that we did when it first came out. The virus has kind of calmed down. That doesn't mean it's not important to get the vaccine. If you're 65 and older, that's still a risk factor. If you've got diabetes, if you have liver disease, if you have heart disease, it's still probably a good idea to get it. And that would, again, the newer COVID strain and vaccines coming out similar to the flu now in August, September. So just to go again through my statistics here and emphasize the importance. If you're vaccinated, you get a against COVID, you get a 53% reduction in your hospitalization when you get the virus, if you do in fact get an infection. For influenza, that's a 69% reduction. So you're going to end up having the flu where you're sitting on the couch for a few days. You're not going to be in the ER or the ICU, God forbid. And then the RSV, a 58% reduction overall. And you can see that the effectiveness kind of wanes over the second year. They may come out with a booster shot on that, but that's yet to be determined because it hasn't been out long enough.
What does RSV mean?
Oh, sure. The question here for our online audience, what does RSV mean? Respiratory syncytial virus is what it stands for.
Cold.
It's similar. It's in that similar family, that cold virus family. Okay, so we'll move on from our respiratory illnesses and get into some of the other vaccines. Shingles. Has anybody in this room had shingles? Yeah, it's pretty common. Yeah. It's not fun. Not fun at all. Shingles is the secondary infection from the chickenpox that you got when you were a child. Chickenpox is varicella virus, and when you get what we call your primary or first infection, you sort of get that head to toe rash. Gosh, and when it's bad, it can go in your mouth and everything. But and you're pretty sick. You have fever and body aches, and you have to stay home from school, and it's usually gone by 7 to 10 days. Now kids don't have to have it though, because they have a vaccine they give children, which is great. But in your group, none of you got that vaccine. I didn't get that vaccine. It didn't come out until 1997, I believe. So then the virus is very smart. It goes away, but it kind of sits in your body at the root of one of your spinal nerves. And it just hangs out there. But your body has built up antibodies, so your body keeps it in check and doesn't let it come out. Well, over time, those antibodies kind of go down because you haven't had that full infection in a while. So the antibodies aren't as strong. They haven't been working their muscles. They're just not there. And of course, the longer that time goes on, the higher risk. So that's why we see this more in 50, actually, in overgroup. So the right conditions can happen. Maybe you're under stress, or you have some other kind of illness going on, or you weren't getting a lot of sleep. And your immune system's kind of worn down, and then all of a sudden you wake up and you're like, gosh, I have this like itchy or burning rash. Yeah. And I put this picture because this is the most common place we see it, but you can get it anywhere on your body. And then maybe in another day or two, you get these blisters and this redness, and then you're like, oh no. And there you are. And so it attacks a nerve as it follows along that path. As we have our spinal nerves come out of our body, they all follow what we call dermatomes into our skin. So it's only going to be in that one dermatome. So it's only on one side of the body. It's never going to be on both. And it's just going to be in a collected patch. Most patients can get over this on their own in 10 to 14 days. If you get in to see a urgent care or your primary care within 72 hours of onset of symptoms, you can take the antiviral, which can decrease the severity and the length of the illness. But unfortunately, there's a subset of the population after the virus goes away, they get what we call post-herpetic neuralgia. So basically what that means is the nerve where that was infected gets inflamed from the viral. The virus kind of went away, but the inflammation's still there. And it can be very painful, even severe enough to have to see a pain management specialist. And that's why we recommend this vaccine, because that can be life altering. And we don't want you getting that. It also, if it gets on your face and in this nerve that kind of innervates down into your eye, it can cause permanent eye problems and even vision loss. So we always get very nervous if we see shingles around the eye and get you in to see an eye doctor right away. And there's some new statistics that came out recently about it increasing your risk for a stroke and a heart attack 6 weeks after the infection, up to like 35-50%. And they don't know exactly why, but the thought is your immune system's totally revved up. All those inflammatory markers are going on. And so you get this other unintended consequence. So It is recommended at 50. The new version that we use now, we don't really use the old version, which was herpes zoster. We use Shingrix. I want to say that came out maybe 10 years ago now. And if you've had herpes zoster and you haven't had Shingrix, ask for Shingrix. You do need to get this one. It's a lot more effective. The old herpes zoster was only about 50%. This one's upwards of 70. It's a live viral vaccine. So those other ones I was just talking about as far as the respiratory, they're not live viral. This one is, meaning it's giving you a little bit of an activated viral protein. So it can give you kind of a reaction. You can get a red, sore arm. You can get a little bit of a rash there. That's okay. That means your immune system's working. It's not, it's not that you have an allergy. It can make you even have a fever. You can feel kind of run down for a couple of days. Now, again, that doesn't happen to everybody, and it's hard to predict who gets that and who doesn't. A lot of times I have patients do this vaccine on Fridays, so they have the weekend to kind of relax. It's 2 doses. You get one. So I give you one today, then you get another one in 2 to 6 months, and then you're done. You don't ever have to have it again. And again, it's starting at 50, but if you haven't done it, even 65 and older, I highly recommend it. And you can see that it reduces the disease burden by 74% when you do get the shingles vaccine. Tdap, I think we're all pretty aware of Tdap. That's been around for ages. Tetanus is that neurological infection that can cause stiff muscles and what we call lockjaw. We don't really see this at all, except, interestingly enough, 2 years ago, I think they had a case in Washington State of a person who got tetanus. And we hadn't seen one in years, and that person was pretty lucky they survived it, but I think they were in the ICU for like 6 weeks. So it's most prevalent in soil. So if you like to garden, you definitely want to have this up to date. If you get a cut, we can see it lives on surfaces like metal objects, dirt. So when you maybe have ever had to have sutures or stitches, they'll say, when was your last tetanus shot? And if it's been more than 5 years, they'll update it. Just preventatively, we like to have it updated every 10 years. If you've had Tdap, you don't need the Tdap again. You get the TD, just the tetanus diphtheria. But you can always ask the provider that's doing it which one's the right one for you based on your medical history. Diphtheria, thankful that we haven't seen a case of this in quite a long time. It's a nasty bacterial infection that attacks your respiratory tract. It also can cause these painful, slow healing ulcers all over the body. Again, just important to stay on top of these things. And then pertussis. Did anybody have pertussis when they were a kid?
Whooping cough. Yeah.
Yep, whooping cough.
I remember that.
Yeah. It's not fun. It's really not fun. And some of the characteristic signs of whooping cough is that you'll hear that whoop because they have to take in a deep breath. And then, especially in pediatric patients, they vomit after they cough. But patients over 65 can get whooping cough, and it's not a good thing to get. The reason it's so dangerous in pediatric patients is little babies have tiny airways, and it can really decrease their ability to oxygenate, and so they have to end up in the hospital on oxygen. That's why if you have a new baby in the family, the mom or dad might ask you, have you had your pertussis vaccine updated? Please do it. We don't need to spread our germs to the infants. And pertussis has come back. We've had hot spots of it all over the country and in Arizona. Not recently, but again, our children aren't getting vaccinated like they used to, so we're seeing it come back. A couple other things for your age group. If you have certain medical conditions or you travel, especially out of the country, you may need a hepatitis vaccine. We have A and B available. So if you've got liver disease, liver cirrhosis, we'll vaccinate you. We don't want a sick liver to have another insult. Certain areas of the world, you can go on the CDC website and put in, if you're going to travel somewhere, your travel destination, and it'll tell you what vaccines you need. We have a travel clinic in Tucson that's reliable. Your primary care can help you with that, but that just lists some of the things to think about when you travel to different areas of the world, especially if it's a third world country. And measles. So this is in the news right now, so I wanted to highlight this. That's a child with measles. That's the very characteristic rash. If you were born after 1957, and you did not get a measles vaccine, you may not be immune. So you may want to talk to your doctor. It's a simple blood test where we can check if you've got the antibodies to it. Sometimes insurance covers it, sometimes they don't. I don't.
What if you have measles?
So that's what I was going to say. If you were born before 1957, we presume that you had measles because almost every kid, like chickenpox in that age group, had it. So you're not going to need the booster. But if you have questions about your own personal history, you can discuss with your primary. So I was looking up the statistics. So we're 3 weeks into the year? We've already had 121 cases of measles in the US, and we had over 2,000 last year. So as of the year 2000, we had none. And this is just 26 years later. So it's really sad. Let's go through some of the myths, and then we can start our questions and answers because I want to make sure I have enough time for you guys to ask questions. Vaccines don't work for older adults. I think I proved that with my other slides, but you can see that they really do reduce the risk of death and hospitalization. I think it's when you're not in the medical world and you're not looking at all those numbers every day, maybe you don't realize how prevalent it is and how much we see that kind of disease in our hospital. Vaccines can have dangerous reactions. Serious reactions can happen. I'm not going to lie. They can be somewhere around 1 to 1 million chance. But they're very rare. So when we look at the benefit of having the vaccine versus the risk, almost always that benefit outweighs that risk. But again, that's a conversation you can have with your nurse practitioner or your doctor if you have questions about it in your own health. And I encourage you to do that. Reactions are different. Mild reactions are common. A sore arm where you got your vaccine, maybe a fever, body aches, chills, feeling run down, tired for a few days. Those are pretty common things. And that just tells you your immune system's working like it should, building antibodies. True allergies are things like lip, tongue swelling, closed throat. That's pretty rare too. I don't see that very often. But again, if you have any questions, you want to talk to your medical provider. Vaccines contain harmful or secret ingredients. I see this a lot, and I have patients who ask me about them. Our ingredients are not secret. They are publicly listed on the internet, and in fact, you can look at the manufacturer ingredients from the bottle that I get in my office. There was some vaccines back in the day that had a small amount of mercury in them. They don't have that anymore, so we don't even need to have that conversation. That's not a worrisome thing. So yeah, I'm very confident that our vaccines are safe. Natural immunity is safer. Of course, natural immunity does work. You build up antibodies, but you have this higher risk of dying or ending up in the hospital and having all kinds of complications, like ending up on oxygen the rest of your life or something like that. Vaccines contain fetal tissue. They do not. There are no fetal parts or cells, DNA in vaccines. There's no aborted fetal tissue that's used to make vaccines. There was in 1960, they used 2 fetus tissue lines to make some vaccines back then, and that's how this myth started. So if that bothers you, please be reassured that that's not going on, and we don't have any kind of aborted fetus material in our vaccines now. And then there's some information out there that people like myself get some kind of financial incentive from the vaccine maker to give you a vaccine. No, actually, our clinics and primary care sometimes lose money on vaccines. They're not a big profit margin. We sort of charge exactly what the vaccine costs and pay for it. They really aren't. They really aren't a moneymaker for us. I personally don't get a bonus. The vaccine maker doesn't, take me to Mexico on vacation. There's nothing like that going on. I really promote them because I am worried about my patient's health, honestly. And that's it. So we can open it up to questions.
Thank you, Natalie. I actually have quite a few questions that came in. So
Awesome.
There's a lot of information there. And so let's go through these ones that I have online, and then you can turn it over to the in-person. Should older adults get an MMR booster?
So that's a great question. If you were born before 1957, you're considered immune to measles. And you probably likely had mumps and rubella as a child too. So no, you don't need one. If you were born after 1957 and you're not sure if you had the vaccine, you can get a titer checked and see if you've got antibodies present. But if you've got a documented vaccine, you're considered immune and you do not need a booster.
Okay. Have you heard about any blood pressure side effects from the RSV vaccine?
I have not. I think when you get a shot, it can make you anxious. And if you get sort of side effects where you feel kind of run down and tired for a few days, it may make your blood pressure go up, but it would not last, I would think, longer than 24, 48 hours.
Okay. There was another question regarding the RSV. Somebody thought it was a 2-shot vaccine. Did it used to be, or is it just one? Just to clarify.
Let me clarify. Let me look it up because we don't give it in our office and I cannot remember.
Okay.
We don't have it available. We direct our patients to the pharmacy, which is fine. You can go to the retail pharmacy. But you can ask your next question while I'm looking that up for you.
Okay. So I have somebody who has a daughter who doesn't believe in vaccines and always says that they make her sicker. How does she convince her that she needs these vaccines? I know you gave a lot of great myth busters to help. Do you have any other suggestions when you're talking with somebody who really thinks that vaccines are just going to make you sicker, not help you?
Yeah, I hear that a lot, specifically to the flu vaccine. I got the flu vaccine 10 years ago. It made me sick. Well, again, these are they don't have the ability to infect you with the virus or the bacteria. So that's sort of a false premise. But if you're getting flu shot in October when the flu and cold season's rearing up and you get another infection at the same time, a lot of patients will assume that their vaccine was what made them sick when in fact they were getting another virus. So trying to tease out that information in a conversation that's sort of non-threatening to a patient where you really, or a family member or a friend, where you really listen to them, acknowledge their concern, kind of tease out the facts can be difficult, but I think it requires a lot of patience. And then I really encourage my patients who are still suspicious, hey, Mayo Clinic, they have great patient information. TikTok, not great patient information. These are the people that really care about you. So talking to your own personal provider, that's the best person because they know you usually trust this person. And that's who you can direct them to. It's just not true. It's just not a factual thing, but a lot of people do think it. And going back to the RSV, it is a one-time.
Okay, great. Thank you. Can certain medications cause a reaction to vaccines if you're on certain medications?
It's a good question. If you are on anything that lowers your immune system, say you have rheumatoid arthritis and you're on one of the biologics for that, or you're undergoing cancer treatment, you need to talk to your oncologist, your rheumatologist, your primary care who's prescribing those to see which vaccines would be safe for you and which aren't. Some of those live viral vaccines aren't. Simple things like diabetes medications, blood pressure medications, heart medications, those don't interact with vaccines.
Okay. And I guess, and related to that, because you mentioned, if maybe you're undergoing some cancer treatments, I know oftentimes do you lose all your immunity maybe while you're going through some sort of chemo treatments or you've had a bone marrow transplant and have to be vaccinated, right? I don't know that this is talked about that very often, but that's another thing, right?
Yes. So there are these sort of one-offs. So if you lose all your bone marrow in a bone marrow transplant, you've lost all your antibodies you built up over time. So your oncologist is going to recommend at a future date for you to get all these vaccines again.
Right. Okay. Is there any place where I can see all of my vaccines in one place to help keep track?
That's a great question because that's very frustrating for people. If you are a part of one of our patients here, or if you go to some of our community partners like El Rio and ACP, we do all use Epic. Epic puts all your vaccines in one area on MyChart. If you're not computer savvy and you don't have a MyChart access, you can ask while you're at your provider's visit. It's easy. It's one button I push. I can print out the whole vaccine record for you. But we also communicate with all the pharmacies in town. So if you go to Walgreens and get your flu vaccine, it can be a little delay, maybe a week or two, but it will import into your chart. 95% of the time. Sometimes we have a little hiccup with technology.
That's
But
great.
that's only vaccines that you have received since you signed up for like.
No, it gets historical too. If there's any because it also is interfacing with some of the state records. So it interfaces with several different agencies. So I get actually a pretty accurate, with Epic, I get a pretty accurate vaccine record. Of course, it's not going to give you your childhood vaccines.
Okay. Is there any reason that shingles would be contraindicated? So any reason that you would not take the shingles vaccine?
Again, it's a live viral vaccine. So a lot of times if you're on a biologic or chemotherapy or you have a weakened immune system, you may not be a good candidate for it. Also, we don't like to give shingles with other vaccines. So if I'm telling you, you need your pneumonia vaccine and your shingles vaccine, I'll probably schedule you 2 weeks apart.
Okay. With the shingles vaccine, is not the vaccine, but actually shingles, is that, does that spread? Is that contagious for other people if you were to have shingles, just, what do you need to do in that?
Yeah, great question. Because I always have to talk about this with people. You cannot give shingles to somebody because shingles comes from your own inside body, that secondary infection from having chickenpox. What you would give to somebody, you are very contagious, it's a highly contagious virus, is chickenpox. So you could give somebody who's never had the varicella vaccine or chickenpox, the chickenpox disease. Infants are vaccinated at 12 months old. So any infant under 12 months old is not old enough to have it. So you want to avoid those infants. And then pregnant women, pregnancy and chickenpox, they do not mix well. It's not a good virus for the fetus. So I always tell my patients, if they have people like that in their family, stay away till your shingles is resolved.
Okay. Now let's see. We answered the RSV. Is it true that measles can also wipe out the immune system?
You mean the vaccine or the disease?
Just says measles, so I'm not certain.
Definitely, I would say no on both.
Okay.
What it can do, just like other infections, is it can, I think a better term would be overwhelm the immune system. And that's how patients pass away from it, because they get that infection that goes into their bloodstream and they die. Okay.
Back on the shingles vaccine, I know you said it's 50 or 50
and above.
50 and above. Is that now being covered by Medicare?
Yes, it is. The Shingrix specifically was not for a couple of years, but I think in 2025, actually, they started covering it.
Okay. So it doesn't matter then if you don't necessarily need to get it before. You can still, I know you said you can get it later on.
Exactly. We used to have to tell patients, oh, you're going to be 65, get your Shingrix because it's not covered. Okay. And on that note, some of your vaccines are covered with your Medicare pharmacy benefit versus at the doctor's office. So your primary care will usually know which ones, because we don't carry the ones that aren't covered with the pharmacy benefit. So you can always ask, and the pharmacy for sure knows.
Okay. That's great. Natalie, thank you for sort of uncovering all of these myths and information that people should know. I think it's really important that we all know sort of what you should be taking, and you really helped to break all of that down today. So thank you so much for being here. I am going to wrap up with our online audience and turn it over to you. So thanks again, Natalie.
Oh, yes. Thank you to everyone that joined us today. I was very happy to be here.
Thank you. Okay, thanks for being here, and we hope to see you again. We are actually going to be back on tomorrow. This will be for Breaking the Silence, the impact of hearing loss. That'll be Wednesday, January 21st at 2 p.m. With Haley Lanou. She is a vestibular audiologist with TMC Outpatient Adult Therapy. If you're interested in joining that class, please give us a call. Our phone number is 520-324-1960. If you are looking to attend either in person or online, we'd love to have you. And we'll see you again soon. Thanks.